Good afternoon. My name is Mehran Massumi, interventional cardiologist here at St. Luke's Hospital. I want to thank the hosts for inviting me to speak at the Global Cardiovascular Forum. I'm honored to be here. Today we will be talking about thrombolysis and thrombectomy for acute limb ischemia. I have no pertinent disclosures to discuss for this case. Acute limb ischemia is quickly developing or sudden decrease in limb perfusion, usually producing new or worsening symptoms or signs, and often threatening limb viability. Usually, if the presentation is greater than 2 weeks after onset of the acute event, it's considered to be chronic limb ischemia. And despite advances in surgical and catheter-based technologies and bypassing, morbidity, mortality, and limb loss remains very high for these events. Therefore, early diagnosis and rapid initiation of therapy are essential to provide the best chance for limb salvage. The etiology for acute limb ischemia most commonly is related to acute thrombosis of a diseased but previously open, often atherosclerotic artery. It could also be due to acute thrombosis of a stent or a graft, dissection of the artery, direct trauma to the artery, result of an embolus from a more proximal source lodging into a more distal discrete vessel, and of course hypercoagulability. In acute limb ischemia, these patients otherwise have normal underlying vasculature. After acute arterial occlusion, collateral blood vessels cannot be recruited quickly, and signs of acute ischemia develop rapidly. And if you remember from medical school, the 6 Ps: pain, pallor, poikilothermia, pulselessness, paresthesia, and paralysis. Acute-on-chronic limb ischemia, on the other hand, these are patients who have known peripheral arterial disease or have had prior revascularization. The symptoms can develop over a variable time period, hours, days, sometimes even weeks. And suddenly increasing symptoms in patients with history of PAD is indicative of acute arterial thrombosis. And there are different categories for the ischemia that we should all be aware of. For viable/marginally threatened ischemia, there is no immediate threat of tissue loss. There is no sensory loss or muscle weakness. Audible Doppler signals are still able to be found in both the arterial and venous circulation, and these limbs are salvageable if treated promptly. Immediately threatened limbs, there is sensory loss that involves more than the toes. There's also rest pain that's present. Mild to moderate muscle weakness can also be seen. There will be an inaudible arterial Doppler, but there will be audible venous Doppler signals. And this is still salvageable, but there needs to be immediate revascularization. And if there is finally irreversible ischemia, there is major tissue loss or permanent nerve damage. There is both sensory loss and muscle weakness is profound. There is paralysis and sometimes even rigor. There is both inaudible arterial and venous Doppler signals, and this requires amputation. There is no reversible surgical or percutaneous therapy for this to be done. So let's move into our case presentations here. I've had 2 cases in the last 3 or 4 months that I thought were pretty interesting and pertinent. Both are on the acute-on-chronic limb ischemia side of things, but I think they're actually pretty interesting cases. First one is a 49-year-old African-American female, history of hypertension, diabetes. About a year ago, had aortic valve endocarditis that underwent surgical repair, the replacement, with complicated hospital course due to septic embolic phenomenon and septic shock. She had septic emboli to both the brain, liver, and kidneys. She had dusky toes of her right foot at that time, but was sent home with local care. She has had no follow-up since discharge except by telemedicine visits. 1 year after her surgical operation, she presented to the ER with acute-on-chronic critical limb ischemia and gangrene of the right foot. Imaging that was done was a Doppler ultrasound that suggested high-grade stenosis of the proximal anterior tibial artery only. These are our pictures. As you'll see on the left-hand pane, this is our aortogram, which showed a very patent distal aorta and iliac system with no obvious signs of any kind of stenosis or occlusion. On the right-hand pane, we have our distal superficial femoral artery, which occludes abruptly. There's a collateral network which then reconstitutes in the tibial vessels. You might be able to see that there is a patent anterior tibial, and there's both a patent perineal and posterior tibial. So she has about 10 centimeters here of completely occluded distal SFA popliteal artery. So because we knew that her symptoms were on more the acute side, we decided to do something called rotarex thrombectomy. And this is a little cartoon of how this device works. It works over an 018 wire called a rotarex wire. It's made by BD. And this device is both indicated for thrombectomy and atherectomy, but in my experience it's better for thrombectomy. It has a beveled tip that helps to break up the thrombus and atherosclerotic plaques. And then it has two windows that will help to actually suck in the debris so that it is not embolized downstream. And it works very, very well, especially in thrombus. And we won't have to go through this entire presentation, but I wanted you all to see that this is one of the newer novel therapies that are available for this space. And this is what we were able to pull out. This came out completely in one piece, and as you can see, it's the size of a hemostat. And we were amazed that we were able to pull this all out in one piece through that device. We thought it would be churned up, but again, it makes for a very good picture. And this was her circulation immediately after we had pulled that out. She didn't even really require balloon angioplasty. Whatever that substance was sitting over there of the popliteal artery, and once we took it out, she had restoration of blood flow with the patent 3-vessel runoff. And she's been doing much better. Next case is one that happened more recently. It's a 44-year-old African-American man who presented with pain in his left leg and felt poor overall. Of note, about a year and a half ago, he also had acute limb ischemia on the contralateral leg, on the right leg, and at outside hospital had a very detailed surgical procedure which included open right common iliac and external iliac artery thrombectomy, SFA thrombectomy, popliteal thrombectomy, as well as all the tibial arteries, and it required a full compartment fasciotomy of the right lower extremity about 16 months ago. After that procedure, he was doing well. He was placed on Coumadin, for which he was taking faithfully for about 6 months, and then really never followed up with anybody, and unilaterally decided to stop his Coumadin. And he came to me about last week and said he has been having left leg claudication for about 3 or 4 months, and it's progressively worsened over the last 1 to 2 weeks, including now having numbness in his left foot at rest and a new purplish discoloration over all the toes. On physical exam, he had no palpable or Dopplerable left pedal pulses, and very strong 2+ right DP and PT pulses. The toes of the left were both cool and had decreased sensation. His Doppler that he had in clinic showed that his right side of vessels were all patent with pretty normal waveforms. The left side showed that he had a full occlusion in the mid-SFA and no flow visualized down to the foot, period. So here's again our picture from our procedure that we had. First thing we did was a aortogram as we usually do, and then we went up and over to the contralateral leg. We had a right common femoral access, went to the left leg, and you see that there's an abrupt occlusion of the mid-SFA over there. Next pane down, again, no flow going down all the way to the popliteal. We see a small little geniculate from a collateral, likely from a profunda, and his tibial runoff was very, very poor. Had a scant distal dorsalis pedis, and that was really just about it. So we came from that dorsalis pedis. We put a V18 wire through a pedal sheath, came all the way up through the clot, through the thrombus. We were able to cross it fairly easily. We had a catheter from above, and we sent our wire from below into the catheter from above and externalized the wire, essentially having body floss. And because of the dense thrombotic burden this patient had, we decided to put a ECOS catheter in, which is a lytics catheter that uses ultrasound to slowly drip TPA, and we put it in for about 72 hours. And so this is a little cartoon on how the ECOS catheter works. Has multiple fenestrations. This cartoon is showing it going into a pulmonary artery, but it can be used in any vein or lower extremity artery. Once you are able to cross the thrombus with any wire of your choosing, you advance this catheter through it, usually over an 035 system, withdraw the wire, and then there's an inner catheter that sits inside the ECOS catheter, which is what actually develops the ultrasound, or emits the ultrasound, I should say. And through multiple fenestrations through the catheter, TPA, thrombolytics are slowly dripped continuously. And for PEs, we sometimes leave these in for 6, 12, even 24 hours. For arterial occlusions, because of the dense nature of it and the length, you can leave it in for 24, 48 hours on average. We decided to leave his in for a little bit longer than that. And we had very, very good results. So we were able to open up his entire SFA up until the distal SFA P1 segment of the popliteal. And he actually now is showing to have some more patent tibial vessel runoff as well too. He had a very patent perineal, and his symptoms had abated a little bit after the 72 hours of the ECOS catheter. And then after that, we decided to do something called penumbra. Penumbra is a mechanical thrombectomy, and this is a cartoon showing that. And there's different size penumbras. This is a great device. We see this a lot in the coronary space for patients with ST elevation myocardial infarctions. We use the small penumbra to perform thrombectomy on the coronary arteries. You can use this in the veins, 12 French. I understand it coming out with the 16 French also for the venous system. Again, for the arteries, we use 7 French or a Cat 8. Very, very, very good results on this. It's very, very powerful, and it's also atraumatic to the vessel itself too. So we've had some very nice results both in the venous space as well as the arterial space. And you can see it's sucking up the thrombus here. There is a fairly decent amount of blood loss with this, and that's something that you should keep an eye on. And the canister is a clear canister. It's very easy to see how much blood loss you've had, something to keep an eye on. But this was our result after penumbra. And as you can see, we have now wide open flow. If you look at the left pane, there's a small area of residual stenosis in the middle of that picture there. We ballooned that multiple times. I think we had a small dissection plane over there. So ultimately, we decided to do stenting with a covered stent called the Viabon. And our results were very, very good. We were very happy with that. And then as you can see down in his tibial vessels, had a patent AT and a patent perineal. And by the time we were done with the case, he had biphasic flows in both his anterior tibial artery as well as his posterior tibial artery. Last but not least, the one thing I want to show you all before we leave is a new device coming from Abbott called the JEDI. This is very similar to the penumbra thrombectomy system, but at the very tip of it, as the thrombus is being sucked into the catheter, there is a jet of water that pulsates and breaks up the thrombus so that the actual catheter does not become clogged with the thrombus. And this has been shown to be very, very effective. Here at St. Luke's, we're currently in the process of trying to obtain this here, but it is commercially available at this time. And the early results have been very, very good with this device. So something to keep an eye on for the future. Well, thank you very much for your time. It's been a pleasure.